Hello there, this is David Benedictus. Welcome back to CoolCouve.
And I'm Daria Ruggles. We're glad to have you back at CoolCouve.
So we're going to talk with Dr. Marcia Roi today, who is in charge of Marcia Roi, who's in charge of the Bachelor of Applied Science and Human Services degree that includes both substance abuse and mental health, and that's through Clark College. It's a 4-year program through Clark College. And I just saw the article in the Columbian, and I was thinking, well, I had worked in mental health, designing mental health chemical dependency program for the Medicaid population back in back in the early 2000s, and I was thinking, well, boy, this is great to see this coming together, this combined approach. And also, there's been a lot of talk about substance abuse during the lockdown, and also as we talk about homelessness, and we had done a number of programs on homelessness, and that always came up about what was happening, the chicken or the egg. Do people get on, or they become homeless because of substance abuse, or do they start substance abuse after they become homeless? And it seems to be both and more in terms of that. But before we get too deep into the weeds there, can you talk a little bit about your educational background and how you came into doing this work?
Absolutely. And thank you for inviting me, David. I really appreciate it. I have been a substance abuse counselor for 38 years now. And I started out my career. I have a bachelor's in psychology, a master's in community counseling, and a doctorate in adult education. When I decided I wanted to teach counseling, I realized I needed to learn how to teach, and found out it's more than just talking. So I started out my career in domestic violence. I ran a domestic violence shelter in Oklahoma. And one of the things that I realized early on is drugs and alcohol were always in the mix. Ask the women, does he hit you when he's sober? No. So that's when I decided maybe I need to go upstream a little bit and see if we can tackle this problem earlier. And so became certified in this field. I've worked in inpatient, outpatient. I have a facility, my own facility, which was 14 beds for adult males, and then 3 satellite offices we had to cover 3 counties in rural Oklahoma. And one of the problems that we had way back then, which is decades ago, was pharmaceuticals. Because we had a large VA regional hospital in Muskogee, Oklahoma. And so between that and the Cherokee hospital, there were a lot of pharmaceuticals. So I became entrenched, ingrained in part of my DNA in substance abuse counseling.
So what do you think is missing now in terms of the way that things are being taught, and how do you expect that to inform things in the future?
Well, I'm pretty happy the way that we're going. At this point in time, for example, when I had my facility in the mid-'80s, there were no programs like this. There was an idea that life experience was enough. And so the people that I hired, if you had a year's sobriety and you had a sponsor, they made you a counselor. And some really bad things happened. As far as no teaching of ethics, no teaching of boundaries. And so when I came, for example, so some of the things that I saw, horrendous abuses of clients. And I should probably thank those counselors, because those are the ones that got me to going back to school to decide to teach counseling. I had a colleague who said, I was complaining about one of the counselors that was being fired for soliciting with the clients, believe it or not. And I was complaining about that. And she said, go do something about it. And I said, like, what? And she said, go teach counseling. And I said, really? And this was in a hospital. I was working in a hospital in a dual diagnosis unit. This was during the crack cocaine epidemics in South Chicago.
Mhm.
So we were really rocking and rolling. Everybody was on crack cocaine, and they also had mental illness, but they were being treated separately. And so as far as training, I'm pretty happy with the training that we do here. When I came into this field, I had an agenda, and the agenda was to create competent, caring people who could adequately serve their clients. And so we've been pretty successful at it. As far as jobs, my students are highly sought after. Not all students that start the program finish the program. Many of them self-select out. They realize that either they have to do some work on themselves because they bring issues in. When you're talking about the trauma-informed care, people bring trauma in, their own trauma.
Mhm.
Many times that's what motivates people to be a counselor. I went through all of this, and while some of those experiences are useful, they could also be too much baggage to be a good counselor.
How do you measure for that? How do you examine that?
Our program is what we call a high touch program. It's not high tech, and I'm not high tech either. So I am always on speed dial for the e-learning people. Can you help me with this?
Yes.
We check in with students every term. And our instructors, all of our instructors are practitioners, and that's by design.
Mhm.
So they have the same passion that I do. We're trying to train up the next generation because we see some of the abuses that have been happening. And our hope is to make it better, basically. We have conversations with students, the coursework, things bubble up through the coursework. And when we see something that's a red flag, we'll pull the student aside and say, you know what, you've got some biases here. And you need to really look at this. What's going on here? What's happening? And for an example, we have a class that the skills class that I teach, and that's kind of where the rubber meets the road. Can you sit down and have the interview with the client without it being all about you? Okay. And so I look for that. So
Was that the previous model when you was talking about people that were basically peers as counselors?
right.
Was that the model about sharing your own experiences? And that way people would feel like they were part of a community, a healing community or something? Or
But even the 12-step, even back in the 30s, the 12-step book, what they call the big book that was written by Bill W., recognizes a problem in that he called it terminal uniqueness. In that people will say, you don't understand me. I am terminally unique. I am so unique. Even in the substance abuse field, you see that. Well, your drug of choice was heroin, mine was meth. You don't understand me. Okay. So in our field, we encourage as little self-disclosure as possible. And one of the reasons for that is you don't know what's going to happen with that client. So the peer model is a good model but it's not a clinician model.
Mm.
And the problem is that those lines get blurred many times. I had a student years ago, and we were talking about you don't self-disclose. Whether or not you are in recovery to begin with, one of the reasons is because it can backfire on you. And the student can reject you because they have their own biases. And one of the students said, oh, I always share. You just don't understand. I always share. And then a few weeks later, she came back to class and she said, Dr. Roi, I got a problem. I said, why? She was doing an internship, her internship at a treatment center as a trainee. She said, I have a client now who showed up at my church. She showed up at a family reunion, and she showed up at my softball game, and she wants me to falsify paperwork to keep her out of prison. And she shared all of that, so the client knew where to go.
Mhm.
And she said, what do I do? I said, well, go to your clinical supervisor to figure this out to begin with, because that's stalking. Another reason, as far as sharing, whether or not an individual is in recovery or not, we never ask. Most people don't know that being in recovery is from substance abuse is covered by the American Disabilities Act. So we don't ask whether someone has a disability or not. If a student shares with me, I'm in recovery, then I can ask, well, how much time do you have? You know, but we're never asked, and employers should never ask because that's a disability.
That was one of the questions I had, and because a lot of the programs used to require that you were in recovery, as I understand it. And so this is a different way of looking at vetting people to become a clinician.
Mhm.
And so why do we need to have substance abuse and mental health treatment combined together in the same place, offered by the same clinicians?
Well, because they're two different entities, really. They're, you're looking at two different cultures. And I'll give you the example of how the substance abuse client has much more denial than the mental health client. The mental health client presents and says, I'm here, I'm anxious, I'm depressed, I want you to help me. The substance abuse client presents and says, I'm here, I'm anxious, I'm depressed. My wife complains about my drinking, and she's making me anxious and depressed. I think she needs medication. I'm fine, thank you. And so you don't have as much denial, and you have to do some mental gymnastics, and you have to do some skillful you have to have some skills to help the client get around that denial, to confront that denial. Now, in the past, what they used to say is, oh, well, the client has to hit bottom.
Mm-hmm.
What does that mean?
Well, treatment centers would actually, when clients acted out, if they got angry or if they acted out, they would actually kick them out of treatment. Okay. The anger and the acting out is a symptom of the disease. This is a disease. And you wouldn't see that in mental health. Okay, he's depressed, but he's not suicidal, so let him hit bottom. You wouldn't hear that. Well, let's wait till he's suicidal, then we'll treat him. But you saw that in substance abuse treatment. And you heard the clinicians saying, oh, well, he just needs to go out and drink some more. Well, he may die or become suicidal. And so this idea of, quote, hitting bottom, if you are looking at this, what we've done with substance abuse is we've treated it as an acute disease, as an acute symptom. We put somebody into, say, residential treatment, 21, 28 days, put them out there, and when they relapse, we're surprised. Well, hey, you went through treatment. this is a chronic disease. So I liken it to tooth decay. That's a chronic disease too. Your teeth don't heal up. And so if you went to the dentist, you had a cavity, he filled the cavity, you went back to the dentist and said, I have a second cavity. And he said, what's your problem? I filled the first one. And people have this mindset with the same thing with substance abuse. Well, you went through treatment once. So like you're never done with the dentist, right?
Mhm.
You always got to get cleaning, you got to get this, you got to get da, because it's a chronic disease. The same thing with diabetes. So the big change on this, now we've recognized for many years that mental illness is a chronic disease, but not so much substance abuse. It's been treated as an acute episode.
Mhm.
And so what came about was called the Recovery-Oriented System of Care, ROSC.
Mhm.
And the recovery-oriented system of care shows that, research shows that if you can keep someone in the system for 3 years, they have a much better rate of recovery. And that doesn't mean that you keep them in a rehab center for 3 years. But when they come out, you have a step down process.
Mhm.
So for example, if we use diabetes, if someone ends up in the hospital because of their diabetes, they have wraparound services when they come out. There's a nutritionist, there's maybe a home health aide, there's follow-up appointments, and that could be for lifelong, that you're going to have an appointment with your physician or with the home health aide or whatever to manage that chronic illness, as opposed to just, you know, sort of spin drying someone for 28 days and then putting them out there. So one of the ideal systems is residential treatment, outpatient intensive, 4 days a week, aftercare for 4 days a week for maybe 3-4 months, with other services. And then aftercare, the one place I worked at one treatment center, we had aftercare for 11 months with the spouse. Okay. And we can talk about codependency being a saboteur, the partner being a saboteur of the sobriety, which is counterintuitive. But it happens a lot.
Mhm.
So treating that family as a system,
Mhm.
and for a year, and then following up, and that's where the peers come in. So the peers would come in
Mhm.
to just sort of check up, how's it going, how's it going, how's it going, and the peer could be the red flag. You know, Joe's having a hard time here, let me contact the treatment center and see if they can sort of loop them back
Mhm.
before the relapse happens.
Mhm. So, Dr. Roi, can you talk a little bit about your curriculum? Like, what are the kinds of educational processes or that you're teaching, and who are the teachers besides yourself? Mhm.
I'm very happy to have the teachers I have right now.
Mhm.
Very happy. The professors that we have, as I say, are all practitioners. They're all doing it out in the field.
They're- What kind of
Yes.
practitioners?
Oh, one of our faculty that's been with me the longest is Jim Jensen. He's the coordinator. He's a manager of collaboration and learning for the Southwest Affordable Communities of Health.
Mhm.
Currently, he's working with the True Blood Settlement, which is to get forensic mental health, get people assessments quickly if they're in the criminal justice system.
Mhm.
He's been with us for about 13 years. I have Karen Veteran. She has been working, she is teaching trauma and grief and loss. We have a whole trauma class. And that's where things bubble up to in a class like that. We have another of our practitioners is Catherine Kroll. She's an epidemiologist with Peace Health. She teaches here and bloodborne path system. She's the one that told us how long the pandemic was going to last, and she's been right on. And we have Sarah Blanchett, who is a DSHS supervisor. Sarah Carlson, who works for Peace Health. She is a trauma specialist also. She deals with crisis, mental health crisis. We have Jimmy Evans. He's an alum of the program. He is a private practitioner. He's in private practice. And who am I missing? We have Angie Ball. She's a clinical director at Daybreak Youth Treatment Services.
Mhm.
Andrea Belle-Isle. She's also a clinical treatment director at Daybreak. She works in outpatient youth. And I'm trying to think who I think that's everyone. So everyone out there, pretty much, they're in the field. They know what's expected of counselors. They
Mhm.
hire counselors. They recommend for hiring. And we have Tabby Stokes, who is a prevention specialist. And she works with youth also. And has for a number of years. She is well known in the field of prevention here in Clark County. She is an alum of the program. So I have students who have graduated from the program 10, 15 years ago and come back to teach now. So they can tell the students, this is what's expected of you in the field,
Mhm.
what counselors should be doing. This is what an effective counselor is. And I know some of them are shopping in the classrooms.
So those students can get jobs.
They do get jobs.
Yeah.
They do get jobs. Yes. We have a field placement for the bachelor's program, and where the student goes in for 2 terms. The first term, they go into the agency and they construct a learning plan. And the skill that they need to work on is negotiation. So they negotiate the learning plan with the treatment director.
Oh,
These are the things I want to learn. Everything is competency-based. These are the competencies that I want to learn. And what do you have here that can help me with that? And the treatment director would say, that's good, but these are the things that we need done. So how do we blend these two
Mhm.
and negotiate this learning plan? So they do that in the first term, and they learn the climate and the culture of the agency and the resources and their mission and all of that.
Mhm.
Then in the second term, they write a grant proposal for the agency for a program that the agency wants to develop, because every program they have, every agency has programs they'd like to develop, but they're too busy providing services to do it. So they don't have time to do it, but the intern does. And they have the skills. There's a research and evaluation course that they take to learn how to evaluate programs. They have to take statistics before that to learn how to create programs, to learn how to write grant proposals. So they come out with those skills. And I'm delighted to report that one of our first graduates wrote the grant, and it was funded. And the agency hired a part-time to work the grant.
Wow, that's wonderful. Because I was going to ask you about funding for students, because, you know, there's this terrible in debt for so many students that are coming out. And not only do they have debt, they're not finding jobs. It sounds like you're really addressing that on a.
No, they're finding jobs. They're finding jobs. They find jobs beforehand. In the state of Washington, in order to sit for the state exam for addictions, you have to have 90 college credits, which is your 2-year degree.
Okay.
And then you have to have 2,500 hours experience. And those are paid positions. trainee positions. They get their trainee credential from the state, and then they work as trainees. And so many of them are doing what we call a learn and earn.
Mhm.
They're working while they're going through school. The vast majority of my students are part-time. Most of the students are midlife career changers. They're coming back through various means. Sometimes it was downsizing, death in the family, divorce, something that brings people back. For some people, this is what they've always wanted to do, but they've been working a job they didn't care for 20 years in order to launch the kids. And now they want to do what they want to do themselves.
So I'm very curious. Earlier, Dr. Roi, you talked about how this training brings up a lot of personal trauma. So in your experience, have you found that most people, because they are coming at this in a way of wanting to help others, do you find that most people are dealing with it? Or have you had somebody that you're just like, look, you know, there's too much work for you to do? I mean, how is that personal trauma informed this process for people in your experience?
You know, as far as addictions, about 50% of our students are in recovery, about 50%. Other people have always wanted to be helpers, and so they've come in with that. And like I said, we pull people aside and say, you know, in my professional opinion, you need to go to counseling for this. You've got a bias, okay? And I'll give you an example. So I had a student who was in a field placement. This was for addictions. And we were in one of the meetings for her field placement with her supervisor. And she said, oh, I've got this woman and she's on my caseload and she's hostile and she's angry and she's resistant and she's in denial. And she was just, we got to kick her out of treatment. And, you know, and I'm watching this. And she said, she folds her arms in group therapy. And I said, okay. I said, you know, most people are angry when they come into treatment because they don't want to give up their drug. That's a relationship. They don't want to give it up. And anger is something that bubbles up. And I said, let me ask you a question. If this individual were a male on your caseload, would you have the same feelings about them? And don't answer me right away. Go in here, inside, and answer me from here, not in here, in here. And she thought for a minute, and she had been through the program. And we do this a lot. So she knew what go in meant. And she said, no. And I said, okay, so what is it about this woman that is different than the other women that you're working with? Don't answer me right away. Don't answer me from here. Answer me from here. And she spoke, and she took a minute to think about it, to let it settle in. And she spoke in that voice of absolute truth that you know that it does come from the very core. And she said, the woman is in a battering situation. And I have to watch the fresh injuries every week because she's not ready to get out yet, which is not our call. That's not for us to say. And then she stopped and she said, and I was there 15 years ago. What had happened was she had never really forgiven herself in that relationship 15 years ago for being battered. And she wasn't going to forgive this woman. She thought when she closed the door on that relationship that it was done. But she hadn't processed because she hadn't forgiven herself. And we are the first relationship that we have, our relationship with self. If that's not right, any other relationship is not going to be right.
So what's the science that supports the relationship, the connection between trauma and substance abuse or any addictions? We've been talking about substance abuse, but there's food addictions. Gabor Mata, who does this work up in Canada, talks about addiction to buying classical music, just huge amounts, and how that it's an obsession process. So maybe just we could talk a little bit about what addiction is in general, and then its connection to, and why the science is making the connection to trauma as part of that.
Well, we can pull back and talk about what addiction is. Okay, so addiction to me is part of human nature. Okay, there's nothing in the addict's head that's not in our head. Nothing. Have you ever bought something in a store that you don't need?
Oh yeah.
Okay, you don't need it. You're standing in front of the cookie aisle, right?
Yeah, right.
You don't need it. Okay, but there's a conversation that happens in your head, right? Just like you tell yourself you're going to clean up your food act, and then some fool at work buys donuts in the break room. They're sitting there calling your name. Before you reach for the first donut, you have to make it right in your head. I'll skip lunch. I love the person who breaks the donut in half, because you know they're coming back for the second half. You know that. Right? And oh, I have so much willpower, I can eat half a donut. No, you don't, because you're going to wait for me to leave and you're going back for that second half. But you have to make it so there's this conversation. I need this, I want this, I deserve this, I'll skip lunch. This whole thing, right? As you're standing in the store, maybe whatever it is, it costs too much. Now you got to figure out what you're going to tell your spouse when you get home. I want to tell my partner. And maybe you don't exactly tell them how much it costs. Okay. Because we always talk about addicts being dishonest. Okay. But you didn't tell them how much it cost. Or you hid, the pair of shoes or whatever it is from them. When you're standing in the produce aisle, looking at the lettuce and the kale and all that, you don't have that conversation. You don't have to justify eating broccoli. But when you're in the cookie aisle, you have to justify that, or the ice cream freezer.
Ice cream, there you go.
Okay, you have to justify that. And the difference is guilt, isn't it? Whenever we're, as human nature, whenever we're in a situation in which guilt is there for whatever reason, okay, that conversation starts. That rationalization, that justification. All of our students, whether they're in the bachelor's program or the 2-year program, they all start with the addictionology class, and they all give something up for the term. And journal it. And they journal it. And they start out with, oh, this will be easy. Really? Because you can't understand addiction intellectually. Intellectually, it doesn't make any sense. Well, how could this woman give up her children for this drug? How could you do that? You have to understand it emotionally, because it's a relationship. This is my comfort. This is why everybody's been packing on the weight during the pandemic, right? Because there's a relationship. That relationship is not with carrots. It is with
pie.
It is with ice cream. It is with candy. It is with bread. It was for the entire pandemic. I have not bought bread, because that's my relationship. That's my go-to. That's my comfort food, is bread, cookie, or all of that, bakery. So we recognize that it's a relationship. It's intellectual, just like your morning coffee. There's nothing logical about that. There's no vitamins in there. You know, now they say there's antioxidants and people say, oh, well, there, okay, there's more justification.
Yeah, there you go.
You know, but if you have high blood pressure, the first thing they tell you is cut the caffeine out, right? But it also makes your brain happy because you get a dopamine dump with the caffeine. There's nothing logical about it, but if you take, people will hurt you if you mess with their morning coffee. And so, and we have this relationship with it. And the reason that the K-Cups became so popular is because we like our relationships to be consistent. We don't want any surprises with our relationships. We want them to be comfortable and consistent. With the K-Cups, you get that consistency. My office has been across from the faculty lounge for 20 years. I've heard people go to fisticuffs over that coffee cup, over that coffee maker. I'm the tea drinker, so I'm out of it. But I have to have my tea in the morning. So, so you have to understand it emotionally. I need this, I want this, I deserve this, it's who I am. I'm a coffee drinker, or I'm a tea drinker, or I'm a heroin addict, or I'm a whatever, okay? It's who I am, or I'm a smoker. And so it's a relationship for me. People say, well, why did so-and-so show up at his father's funeral drunk? Well, his father just died. If your father just died and you went to the funeral, wouldn't you take your best friend? Well, his just happens to be Jack Daniels. So of course his best friend came with him. Of course he would show up drunk.
So what's, if it's an impulse in all of us, and it sounds like also you're talking about it, a relationship and also an identity, like it's not just what I do, it's a noun. Where does the pathology enter in?
Well, the pathology enters, we know there's a biological markers. We know that because we can see it throughout the families. So we can see that propensity. And the brain science shows that for some drugs, it appears that the brain is permanently rewired to accommodate the drug because there's withdrawal. And withdrawal is not just physical, it's emotional also. If you cut the caffeine, yes, you're going to get a headache, okay, because your brain has been changed from caffeine. But emotionally, if you tell your spouse, I'm going to quit drinking coffee, they're going to go take a vacation because they know that emotionally. Okay, how do I know this? When the students for 20 years, they have been journaling what happens emotionally and behaviorally. And these are behavioral addictions. I'm addicted to Facebook, sugar. Sugar is huge because it also makes the brain happy. So when it becomes your go-to for everything, because there is so much trauma and you need, this is my source of comfort. This is what I need. And now it becomes the go-to for more and more and more and more trauma.
So the science on trauma and addiction, when did they discover that, and what is the current research on that then at this point? Because you're using that approach now, and you're teaching that clinically, that people have to be aware of that, their own trauma, but also understand what happened. This is a new book out by Bruce Perry and Oprah, What Happened to You. That's the title of it.
And you know, there's scores for what they call ACEs, adverse childhood experiences. we know in the prevention field,
Mhm.
oh, we're studying these folks who have fallen into it. But the interesting part of, so how do you look at the healthy, which is the resiliency literature? How is it that one kid can succumb and the other kid is okay?
Mhm.
You've seen that in families. Maybe the mom and dad, they're both in alcoholism or drug addiction, and this kid follows suit, and this kid just does fine, sidesteps the whole thing, but they both lived in the same environment. And so some of the things that we found as far as resiliency and with trauma, these two kids went through the same trauma. How come? Some of it is genetic. We know there's a genetic link. Some of it is environmental. You know, you say, well, you know, are addicts and alcoholics born or made? Yes, to both, a little of both. One of the things that we have found is that mentoring works. The research shows in prevention that mentoring works. When you talk to people who came from adverse childhood experiences, they will say there was one adult. It was a grandparent, it was an aunt, it was a school teacher, it was a basketball coach, it was somebody in the life. And interestingly enough, the research shows that the child is not a passive recipient of this mentoring. They actively work to continue that relationship. For example, some parents will have, one of their kids has a friend who is in a home that is unstable. And they practically set a table every night for this kid, because this kid is around the house all the time. That child is gravitating towards a healthy situation. But when you examine the behavior, and the parent will say, you know, why can't you act like your friend? He's got better behavior than you. Because the friend is modifying their behavior in order to continue the relationship with that family. The student who is using the mentor, the school teacher, for example, is going to modify, they're actively continuing that relationship with the teacher. They're volunteering to clap the erasers or whatever it is. We don't use erasers anymore, but they're actively, I'll clean up the classroom, or they're volunteering to stay within the orbit of that healthy individual. So the child is not a passive recipient. They actively are working at staying in a healthy situation, even though there is trauma there. Now, what's the difference between the two? We're still looking at that. Why does one gravitate one way and one gravitate the other? That's part of the mystery. Mm-hmm. You know, it's like and I can't remember who, Epicurus, I think, has said, it's not what happened to you, but it's what you took away from that. Mm-hmm. See, two children, maybe their father was an alcoholic, and one of them said, I learned to drink at my father's knee. I learned how to be an alcoholic. And the other one said, I learned that alcohol was poison. Mm-hmm. So it's what you took away from that. I've had students in my program, once they sort of unpack some of the things they've been through, horrendous. And I've looked at them and upside down, sideways, backwards, and they have a solid footing. I had one student who had two sisters, and her mother was alcohol addiction. And what she would do is when she went on an alcohol binge, she would take the three girls and she would put them in a motel room. And she would tell them to stay on the bed, one of those big king size beds. And she would forget to come back for 3 or 4 days. So they were there without food. And she was in my program. And I said, what did you take away from that situation? And she said, my sisters and I are very close now. We call each other every day. We all have our families. And she said, we learned to play games with the bedclothes to entertain ourselves. There was a TV there. And she said, we had a bathroom and we had water. But we stayed on the bed because they were afraid. They stayed on the bed. One would keep watch while the other ran to the bathroom and back. And she said, if I had not had that experience, and her mother had already passed, and she didn't have any anger. She said she thought she was protecting us by locking us in a motel room.
Mhm.
And she said, but what I took away from that was the relationship with my two sisters. And we would not be that close if we hadn't had those experiences. So that's what she took away.
Mhm.
So it's what do you take away from that?
Does it make a difference what age the child is when they experience that? The chaos of the unpredictability.
Well, you know, one of the things that we know is early childhood are
Mhm.
formative years. We do understand that. If there is a shift later, the child may be able to reason it out a little bit more. But we do know that those formative years, those first few years, early childhood education, I have an interim dean and she was director, Michelle Volk was director of early childhood education. And she moved over and I said one day, I said, you know, if you all do your job, you can put us out of work.
Mhm.
If we put more resources into early childhood education, then this trauma might not happen, or they would be able to survive it.
Mhm.
But it depends on, and it also depends on, you know, what you define as trauma. We've all seen people who have perfectly good lives and everything's going fine. There's one little speed bump and they have a mental health crisis. They have all the resources in the world. They have support. They have good family. Maybe they lose their job and that's it. I had an acquaintance of mine and that was his situation. He was laid off. He had resources. His family was wealthy. He had his own home, a condo. He lost his job and he called me up and said, I'm going to commit suicide. I have 38 in my hand. So, and then we have other people who have gone through tremendous hardship and they came through just like the woman with her two sisters.
Mhm.
She went on to graduate. She was very well grounded. She had empathy. She had compassion. She had the well that she was able to give other people. This is a high burnout field. There's a lot of also vicarious trauma.
Yeah, what's vicarious trauma? There's as this information was, the science was coming out in the early 2000s, they started talking about the risk to people who work in mental health and substance abuse, and that they can, even if they don't have trauma in their background, there's vicarious trauma that impacts them. Can you talk a little bit about that? What that means?
In order to do this work,
Mhm.
you have to be effective, but you have to be affected also.
Mm.
You can't be made of cardboard. You are going to be affected by the things that you hear. You are going to be affected because it has a name and a face to it now. Here's the story. The stories I'm telling you, there's no name and no face. But when it has a name and a face to it, it makes it very, very real. And on the other hand, I'm going to say that, and I've been through burnout. I've been through, when I was in Chicago, I worked at a large treatment center that was a large dual diagnosis hospital. It was a lockdown unit. And one of my friends pulled me aside. She says, you know, when we talk, she says, you don't ask me how I'm doing anymore. Mm. And I stopped and I thought about it and I said, I don't want to know. You might tell me. And you might tell me something bad. And so, well, you need to think about that. But I love this work. And I thought about leaving the field at that point. And she said, you tell me about your groups. You know, I talked about this person and the light went on and I talked to him and, you know, and she said, you love this. I said, yeah, I do. And that's when I decided to teach it. But as far as the trauma, that's one of the reasons why we have a high touch program. We have an advisor for the baccalaureate, that's me, and we have an advisor for the addiction program, that's Chris Thompson. Oh, he is our advisor. He works for Superior Court, Juvenile Court, Chris Thompson. Sorry, Chris, I forgot about you. I couldn't do this job without him. And so we check in with the students. What's going on? Do you want to dial back? What's happening? What's going on with the family, especially during the pandemic, because all of this stuff has been happening. You have to be effective and you have to be affected. You have to a certain degree, allow that to settle in on you too, but not to the point of where you can't function now. And so we talk about counselor self-care from the very, very beginning. The first time I meet a student and they contact me and say, I'm interested in the program, that's the first day. I tell them, this is counselor self-care from here on. We're going to balance. You have to lead a life of balance in order to get other people balanced. Because the other thing about people don't understand with addiction and mental health, one of the risk factors for addiction is intelligence. People who fall into the addictions have a higher than average IQ as a group than the rest of the population. Intelligence is actually a risk factor. So they're not stupid people. And one of the survival skills that you have to have is the ability to read people. You have to be able to read people. Effects on drinking. Am I being ripped off by the dealer? What about my mental health? Same thing with mental health. So if you're not in balance, your clients are going to know it. Now, the second half to that story about the woman who had never forgiven herself for being beaten, I turned to the supervisor and I said, what did the client tell you? And he said, the client came to me and said, my counselor doesn't like me. Another counselor. The client picked up on it before the counselor did. She knew it. And so, so it's all about balance. It's all about priorities. A lot of our students have kids at home. And what I tell them is the kids are the priority. They grow up one time. There's no do-over with kids. And so I just had a student yesterday and she said, well, I'm going to start the program. I have a 6-month-old baby. and I'm working full time, and I thought I'd go to school full time. And I said,
That's a lot to put on a plate.
I said, let's start with one class at a time. You got a 6-month-old baby. That's the priority.
Prevention.
That's right. Exactly. Exactly.
So the empathy, so the counseling relationship requires empathy, but that also puts people at risk for the secondary traumatization because they have to feel the emotion of the other person. Is that how that works? And if they don't, then the client can pick that up pretty easily, it sounds like.
Right. Well, and empathy is an as-if situation.
Okay.
Okay. It's an as-if situation. How would I feel as if I were in this? Okay. But on the other hand, that's where we talk about boundaries. Okay, I can understand. And then we have skills, where we use the verbal skills of checking in. Is this what you're feeling? Is that what you're feeling? Feeling this way, that, because I may feel a different way. Well, if I was in that situation, like the friend of mine who wanted to shoot himself over a job. The first thing that went through my head is, well, that's dumb, but I'm not going to say that. Right. And then I got into where he was coming from. But yes, it's prevention, and it's an as-if situation, and it's a continual learning about yourself, because these clients are going to show you parts of yourself. And if you allow that to happen, then you're much less likely to get burned out. Most of these folks, through mental illness or substance abuse, they've lost everything. They lost everything. They lost a 6-figure job, the big house, the kids are in foster care, the car, the families have written them off, all of that. They've lost everything. And so when you are there with them, beside them, helping build back their lives, it changes what you see as important, because now they have changed as far as what they see as important. It's no longer driving the Lexus. It's no longer having a prestigious job. All that's gone. It's having those relationships. It's getting your kids back. And when you are watching that, it changes who you are. It changes your priorities and how you look at life too.
It's amazingly delicate and complicated and personal and all of these things, and yet you're trying to affect systemic change. So I'm wondering, you had mentioned, Dr. Roi, that this has been going on for 4 years, that we didn't know about, this wonderful program. So how have you seen any systemic positive effects, and what would you like to see in the future?
Well, right, one of the biggest effects is the Affordable Care Act.
Oh, yeah. Let's talk about that.
Yes. So the Affordable Care Act uses the recovery-oriented system of care. And it mandates that all of the centers have to be duly licensed now.
Oh.
So all the treatment centers have to have their mental health license and vice versa. That's one of the reasons why we brought in the baccalaureate of this bachelor's degree, because Clark, Skamania, and Klickitat counties were early adopters of the Affordable Care Act. So we achieved this integration in 2016. The rest of the state and country is doing it now. And well, they were doing it in 2020. I imagine 2020 is sort of a throwaway year. But it's just happening now for the rest of the state and the country. So you can't treat them in silos anymore. You have to treat them. So the mental health counselor looks at that client from a very different lens than the substance abuse counselor. And before, we had the clients tripping back and forth between two counselors. So the client doesn't tell the substance abuse counselor they're on Prozac, and they don't tell the mental health counselor that they're still drinking. And they're washing the Prozac down with Jim Beam. Okay, so they don't know why. So the mental health counselor doesn't understand why the Prozac is working, and the substance abuse counselor doesn't understand why they can't stop drinking. So now we've got all of this in one person,
Mhm.
both sides, and it's very different. It's very different view. And then when we bring in primary care, that's a different view.
Yeah, yeah.
Okay. Primary care providers are trained much differently than substance abuse counselors.
Mhm.
We are trained in what we call motivational interview.
Mhm.
At what point, when we all want to change, we're all ambivalent about change. We're all ambivalent. And that ambivalence runs through treatment. Just because someone shows up at the doorstep doesn't mean they're ready to change. Just because you go to the health spa doesn't mean you're going to work out. Because I go and I see people sitting on the equipment just chatting the whole time. And then they go home and say, yeah, I was there for an hour, right?
Yeah.
They're not ready to make that change yet. Okay. So when primary care providers are trained differently. As far as the ambivalence, they have language that says doctor's orders, compliant patient, medication compliant. You don't follow doctor's orders, he gets upset with you.
Mhm.
You will do what I want you to do. Here it is. Okay. Substance abuse treatment, remember that negotiation. That's why it's so important the client learns negotiation.
Is there a movement to train the primary care physicians in motivational interviewing? Seems like that'd be great for weight loss, diabetics.
It is. It is.
Compliance, because then you look at how to work with the resistance that's part of as you said, everybody's issue when they're looking at change. So that might be that's a place in the system where the skills need.
We're seeing some of that. We're seeing some of the peer counselors come in because healthcare providers, they don't understand why this person is continuing to use and trash their health. They don't understand why the mental health client won't take their medication. They don't understand that. And so you have to go to an emotional place because the addiction and the mental illness is part of the identity. It's part of who I am. And so that has to be sorted out. Yes, it is, but it's not your fault you're an addict. It's not your fault you have mental illness, but it is your responsibility to take care of it.
Not your fault.
And that's why, that's why some people have a problem with identifying mental illness or specifically addictions as a disease. Well, that means that there's no accountability. Yes, there is accountability. You know, if he got drunk and he beat the kids or did whatever, there's still accountability. It's still your responsibility to take care of, and you didn't.
When you say that, I think of choices. And when I think of when you were speaking earlier about early childhood education, because, you know, it's a little kid and you're not able yet to have informed consent. But when you start to recognize that you have choices and you can make healthier choices, you spoke earlier about having a name and a face on that. If you're suffering as a little kid and you don't even know what you don't know.
Right.
So I heard your clock ticking back there. So I know we're running out of time with you. So can you please just what would you like people who either are interested in this program or who want to support it in some way? What do you want the folks that are watching CoolCouve right now? What would you like them to know?
I would like them to know that this is a field that they are screaming for people. It's so much in demand. We have a program that is a solid program. It's all night classes, so people can still work. Okay. They can still, and they can do that midlife career change. It's a much needed field, and it is extremely rewarding also. I mean, it's not about you, right? But like I said, it changes how you look at the world.
Mhm. Changes your mindset about
What's important
what's important.
and what's not. So to get the word out, let people know. If you have a friend who says, you know, I hate my job. I have a student now who works at a job. She calls it a soul sucking job. She's in a program. She loves it. Um, if they're looking at career change, say, have you thought about this? And just have them contact me.
All right. Well, thank you so much. I think that we probably are going to want to check in with you and see how things
Sure.
are going in a couple months. And if that's okay with you, and you can,
Oh, sure.
yeah, we'd love to check in with you. But thank you so much for being with us today. This was really enlightening. And it certainly makes Vancouver cool that we have such a great program that you've got going here.
And since,
Well, go ahead.
and we adopted this integrated healthcare model underneath the Affordable Care Act in 2016. So that's why Clark County. So the people that were in policy decision-making recognize the importance of this here in
It
Clark.
was the county commissioners and they did the right decision. They made the right decision.
Mhm.
It was there when they made the decision.
What a wonderful day that must have been.
It was.
Thank you so much, Dr. Roy. So you're going to be teaching in person, maybe coming?
Yes. Yes, I have classes in the fall.
Okay, wonderful,
Excellent.
wonderful.
And we will be going fully face-to-face in winter.
Mhm.
We're going to be online in the fall, but we're going fully face-to-face in the winter.
Wonderful.
We're back in the classroom. Oh, I can't wait.
Yeah, that makes, talk about personal interaction, right? Yeah.
Well, with high touch and not high tech. I mean,
Right,
that
high
seems like
touch.
a prerequisite right there.
Thank you.
Right, exactly.
And we'll put a link to the program also on YouTube.
Oh, thank you.
Yeah.
Thank you for inviting me today. I really appreciate it.
Welcome. Thank you so much for the work you're doing and helping people have more productive, better life and to lessen their suffering.
Yes,
Yes.
yes.
So say goodbye to everybody. You'll be back.
Bye.